If this session is anything like the last session on drug-coated balloons that I went to, the room was absolutely packed and it was standing room only, so I'm expecting people to continue to flood in over the next minute or two. So obviously a great deal of interest in this meeting and in previous meetings, but accelerating now the interest on avoiding a stent where possible. Do you actually need to put a stent in? There are obviously some downsides to putting a stent in, which can be obviated, if possible, by using drug-coated balloons. So we're going to have a session all about that, learning when you can use drug-coated balloons, in what anatomy, are there any reasons why you shouldn't consider using drug-coated balloons. So I think first off, once everyone's managed to get themselves a seat, we will start with Antoinette, who's going to talk to us about the sirolimus-based drug-coated balloons.
Thanks, Dave. So it's maybe to give a little bit of context and where all this comes from and where this sort of renewed energy and renewed interest in balloons has come in terms of angioplasty. So over 60 years, there's been a lot of progress and a lot of innovation in terms of coronary revascularization. And it all started off with bypass surgery, which was great because it got the artery open, but God, it was a bit invasive, wasn't it? And then after that, it moved on to balloons that proved to be really pretty effective, but there was the problem of abrupt vessel closure and problems with restenosis and recoil. And then that developed on through adding a stent to the balloon. So if we put a stent on the balloon, well, we get rid of these problems of recoil and abrupt closure, but we saw then there was restenosis. So, okay, we've got restenosis, so maybe we need to put a drug on the balloon, on the stent, and this is going to deal with that problem. But as we all know, with first-generation stents, there were problems with stent thrombosis related to the polymer, and, you know, stent technology has grown over time, but technology grew with that, and then we came back to the ability to coat the balloon with a drug, and maybe that could deal with the difficulties with restenosis in these arteries. So we've really kind of come full circle right back to the balloon again, and we're now on second and even third generations of drug-eluting balloons, to the stage at which we have almost a profile of drug elution that's comparable to a DES. But, you know, what is so bad with stents? But we've seen this at a lot of these types of meetings. The difficulty is that with a stent, once the stent is in there, there is stent-related MACE that's doesn't plateau. So it's between 2 and 3% per year. And that keeps on going every year. So we, you know, if you follow patients over 10 years, there's no plateau in that, and we see it year after year. So, you know, if we have a patient who's, you know, in their 40s and who's going to have maybe a life expectancy over 40 more years, they're going to accrue a lot of risk related to that metal that's in the artery over that time. So how could we further improve the outcomes in terms of stents? So one is, can we make the struts thinner? And we have certainly made the struts thinner, and we're down to, you know, 60 micron struts now. Bioresorbable polymers have proven to be effective in terms of the stent thrombosis rates. Well, maybe we can get rid of the polymer and just etch the drug directly on the stent, and we've seen that as well. And can we just eliminate the stent, and what would be the rationale and what would be the benefits of eliminating the stent completely? And that's where we come into the rationale for using drug-eluted balloons in coronary lesions. So what could that do? Well, it can preserve the arterial physiology, vasomotion. You don't cage the vessel with metal. You allow for positive remodeling and late lumen enlargement that you won't see with stents. You avoid the metal scaffold and the difficulties with bifurcations and two stents, and maybe you can shorten DAPT therapy. And all that means for the patient is that you keep all options open in the future for the patients in terms of further revascularization, or if it comes to coronary artery bypass grafting. But you need a good device to be able to bring this promise to a reality. And what are the biocharacteristics that you need in order to make this a reality? So you need to deliver large quantities of drug within seconds when the balloon is inflated. You need to distribute that drug within the first few days. You need to get therapeutic levels that are going to be maintained over a period of time, because you need to act in the restenosis cascade, and you need to have the drug there when the smooth muscle cell starts coming in and you start getting the proliferation. So you need to have therapeutic levels up to about 90 days or up to 3 months. You need to have effective drug delivery in the target itself with as little as much embolization to non-target tissue, and you need to have rapid healing, which is compared to a best generation DES. So this is where the SELUTION SLR drug-coated balloon comes into play. So taking all of these biocharacteristics that you're going to need to make this a reality, with technology such as microreservoirs with a polymer which is mixed in with the drug, so it means that the release is controlled and it's sustained and it maintains its therapeutic level over time. And you need to keep those microreservoirs intact, and you need to keep them in place. And using this cell adherence technology, it protects the microreservoirs and protects them particularly in the transfer, because a lot of how the drug is transferred to the tissue is very important, and you need to keep the microreservoirs intact in order to have the drug active at the site. And this all means that it allows for lower dose concentration overall, so you don't have to give a big dose of the drug in the hope that it's going to stay there. With the technology that's there, it's going to remain protected and remain maintain efficacy over the 90 days. So the technology is now there, so now we need to test it, and you need to know, well, is this going to realise the promise? Is it going to be a Cinderella story? So there are 3 enrolling trials from MedAlliance, and it's over 5,000 patients that are going to be studied. So 3 actively enrolling, and there's one physician-initiated trial. I guess the one that we've talked a lot about, and you may have been at other presentations earlier in the week, is the SELUTION de novo trial, which is a very large strategy type trial. And the strategy is drug-eluting balloon strategy versus a DES strategy. And it's all comers, all lesions. PIs are Christian Spalding and Simon Ecclesall. And it's a large study of over 3,000 patients in 50 sites looking at hard endpoints of TVF at 1 year and a non-inferiority or conditional superiority for TVF over 5 years, because that's really where we expect the benefit to come over time, when we see the rate of attrition with drug-eluting stents year per year, that taking the metal away, it's going to benefit the patients. So there was an interim analysis that was presented by Simon over the first 1,000 patients, and looking at kind of early versus late enrollments in sites. So early is the first 20 cases, and late is after that. And so it just shows that with time, centres develop better confidence and choose more complex lesions in terms of calcification, type C lesions, bifurcation, muscle vessel disease that increases as the centre's experience increases. And these are not small vessels that are being treated. They're not treating 225 diagonals or marginals. This is site-reported with reference diameters of more than 3 millimeters in 60% of the cases, and LAD in almost half of the cases being treated. Another question that often comes up is in terms of the bailout with these types of procedures. Do we see a lot of bailout with these? And it hasn't really borne through. And with more experience, there's less bailout procedures as well. So 20% in the first early, and then in the later, where we see lower rates of bailout for these types of lesions. And also with more operator experience in assessing the lesion, where the bailout occurs after preparation, because after time the operator realises that the preparation is not adequate and it's not time to go to the drug-coated balloon. It's time to say, well, this isn't working for this patient, we need to go to DES, so less bailout occurring after the application of the balloon. So we've seen some of the characteristics of the technology and what's happening in terms of the studies that are enrolling, but maybe it's time now to see some of the cases and have some real-life experience. And I think we'll call on Tom, who's going to discuss a case from this study, I think, and there'll be a second case later from Thomas. It's going to be a patient who's not involved in the study.
Perfect. Thanks ever so much, Antoinette. Come and have a seat. Tom, go up and stand at the mic. Whilst we are waiting for Tom to get there, can I just see who in the audience, if you don't mind, is an interventional cardiologist? Okay, quite a lot of hands. Keep your hands up. That's good. Keep your hands up if you use drug-coated balloons for in-stent restenosis. Okay, that should be pretty much everybody. Keep your hands up. I didn't say put them down. Keep your hands up if you treat native coronary disease with drug-coated balloons. Okay, that's quite a lot of people. Okay, hands up if you treat graft disease with drug-coated balloons. No. STEMI, drug-coated balloons. Some. Calcified lesions with drug-coated balloons. Okay, a few more. Bifurcations. Okay, quite a lot. Okay, great. CTO? A few. Okay, great. So we got quite a lot of experience in the room. Tom, over to you.
Thanks, Steve. I'll just say there are bifurcations and there are bifurcations. So that is the question, to stent or not to stent. These are my disclosures. So thank you for the invitation to present, and it has been a huge honour to take part in the SELUTION de novo trial, which has really transformed for us locally in Bristol our attitude to how to use this technology, where I think we were using it very badly. You may criticise me by the end of this and say I'm still using it badly, but there is no right or wrong. 75-year-old lady presenting troponin positive acute coronary syndrome with biphasic T-wave changes. An echo shows regional wall motion abnormality. She has quite extensive cardiovascular risk with a cholesterol of 7.2, LDL of 4.5. This is selected angiographic images of her left system with dominance, relative dominance of the circumflex, and we see there a very critical lesion in the mid-LAD associated with the diagonal and further diffuse disease downstream. So I guess the question is, well, I've randomized her to SELUTION de novo. Would you have randomized her to a drug-coated balloon trial, drug-eluting balloon trial in the very first instance? Would you take her to surgery? How would you intervene? These are all questions to potentially ask.
Does anyone want to comment about? I mean, obviously, surgery is a ridiculous suggestion. He's in the wrong meeting completely. But what about people? People happy to put this into? Anybody not want to consider putting this in the study? I mean, it looks to me like a really uncontroversial case, in a sense, to put in the study. Anybody would be worried and feel it was a bad idea? No, they're all with you at the moment, Tom.
Wonderful.
Okay. Keep going.
There's with me and there's with me. So this is a bifurcation, Medina 111. It is complicated. I mean, you're right, I guess, to dispel the myth of surgery. Antoinette said it's highly invasive. I think we can all agree on that. I think the nature of this disease, sorry as I just try and make it play again, is the problem we have here is very extensive disease, as I hope you may all agree. So the focus is very much on the lesion in the proximal to mid-LAD, but she has huge amounts of downstream disease, and that may well play into the subsequent discussions. The focus is very much on this critical bifurcation lesion, but I think we do have to take into mind the very extensive burden of disease that she has in the rest of her coronary tree. So the next question is, okay, we embark on this being a bifurcation intervention, we're going to randomize, so I might have to go stent, I might have to go DEB, in which case, if I'm going by stent, am I committing to a provisional approach? We are in the presence of Dave Hildick-Smith, who will say that that is a philosophy that you cannot stray from. Or should I be sticking a DK crush? Surely I need to use a lot of metal and cage this vessel to its very best so it will never move again. So actually we've got a lot to consider here procedurally. I maybe overthink things, but actually randomizing her to a trial made my life a lot easier. She randomized, clearly I'm in this room to present this case, to the DEB arm. So the learning that we have had, which has been steep but has been incredibly rewarding, is it from Simon Ecclesall's experience in the UK, this is all about vessel preparation. This is not about the final intervention. This is about preparing a vessel adequately to deliver the drug and to be sure that we're happy that the vessel is in a state where we can leave it with just a drug and not caged by metal. So 2.5 balloon to nominal pressures expanded across the lesion. And then, controversially, we have adopted an imaging strategy locally because that's one of my passions. But interestingly, actually, imaging isn't something that is mandated or actually used by most of the people with extensive experience in DCB. So this is the IVUS evaluation of the LAD. So distally we see nice external elastic membrane. Now we start to see greater disease. Sadly, a bit of dropout around the bifurcation, the wire from the diagonal coming in at about 10 o'clock. And then we see still high burden disease. I'm sorry, maybe the quality of this video isn't great, but there is high burden disease. So just to take some still frames, there's the distal reference, just assuming we're focusing on this bifurcation lesion. We see the ostium to that diagonal is relatively open, but there is disease surrounding the bifurcation. And actually, in that green bar, we have a relatively healthy proximal landing zone. Again, very much thinking in the mindset of someone who's going to be deploying a stent. It's 3.5 proximal, it's maybe 3.0 distal. Here's an imaging run of the diagonal, which maybe many wouldn't have done, but actually to try and better understand the burden of disease, here we see the LAD wire coming in at 6 o'clock and actually relatively high burden disease in the diagonal. And what's interesting, and probably one of the reasons why people wanted to avoid imaging in the setting of DCB, is actually that diagonal comes out as a 3.0 vessel. And perhaps this risk of oversizing and injuring a vessel unnecessarily is one that might commit us into a bailout strategy. But with this in mind, I look to then further adapt the vessel. So here we have additional vessel preparation, a 3.0 non-compliant in the diagonal in the hope of not overstretching, a 3 and a 3.5 to take into account this disparity in caliber between the mid and the proximal LAD. And now we play another IVUS run in the LAD. So this is a very short AV loop of the IVUS, but just really to show very extensive dissection. And I think one of the other concerns here was that in using imaging, it may trigger us towards bailing out because we start to see images that we're not comfortable with.
Yes. Can I stop you there just for a second? Angiographically, I mean, we didn't see, I think, the balloon in the LAD, but angiographically, who feels happy that this vessel has been adequately prepared? Show of hands, or yes, so perhaps a majority of those who are going to do this case feel it's probably been adequately prepared. Did the balloon come up all right as far as you're concerned? Okay, yes. And of course, we have to remember that the method of angioplasty, the mode by which angioplasty works, is by creating a dissection. So, of course, it's no surprise that we see the dissection on the IVUS, but as you rightly say, that may make people nervous.
It looks pretty ugly, doesn't it?
A little bit ugly, yes. I've seen uglier, but who, if anyone wants to commit, is feeling, okay, this doesn't look great, I think maybe a stent is a good idea? Nobody? Okay, well, that's good. That means people are gaining some experience. Maybe you think a stent?
One aspect, one important aspect here is the do you have IVUS imaging of the dissection in the beyond the diagonal, distally to the diagonal? There is by angio there is a clear dissection. Do you have the image of that segment?
So here.
Yeah.
Yes.
Over there, because by IVUS, we can have a better understanding of this section if the true lumen, the false lumen are well, I mean, if there is thrombus in the false lumen, I mean, this is a bad dissection. If you have a good flow also in the false lumen, this is a good sign.
Just a short comment. Thank you for the opportunity and thank you for the nice case. I just wanted to mention that I feel myself that from the generation that I learned that stenting is the way you go when you have coronary artery disease, and we were taught by people that did a lot of POBAs in the previous decades. So myself and maybe colleagues from my age we feel comfortable stenting, not DCBing or living like this. Personally, proximal LAD with such kind of dissection, I would not leave it without a stent. But this is my opinion, because we were taught that you have to stent, especially when you have dissection, especially in the proximal segments. Thank you.
Excellent. Thank you for making that comment. Remember, though, that the people who taught you had only the experience of being able to use a balloon and no stent, and that's why they got so terrified of dissections, because what do you then do with an occlusive or spiral dissection? So that's why they have that bias. Okay, Tom.
Yeah, and great comments. I think you're not alone in having that concern around here. And I must confess, I have, there's a responsibility in taking part in a study like this, and equally outside a comfort zone of normally treating with a stent. And how far are you pushing it? So these are the ongoing challenges. Oops. So I think then I go to a second. How did I treat? Sorry, it's broken into two.
May I comment about the dissection as well?
Yeah.
So, which is very important, we have to estimate the flow, obviously. If you look at the international consensus guidelines, we have to have normal TIMI flow. I think that was the case here. And if the consensus document guideline is obeyed, then the acute occlusion risk is very low. If you look at the randomized trials, basket small 2 trial and debut trial, there were no single acute occlusion in those 2 trials. So TIMI flow, less than 30% recoil. We don't know what to do with the IVUS at the moment, to be honest. Yeah.
No, and sorry, I show the IVUS not to suggest that imaging is something that we should be using, but really from an educational perspective, because I think it gives us some insights into the dilemmas that we face by an angiogram, which is a very crude assessment of the vessel. So as Thomas says quite rightly in the study, the requirement to proceed is that we have less than a 30% residual. Everyone agreed that there was adequate preparation. Dave didn't ask if there was too much preparation, but the question then is if it's too much, if there's a dissection that you worry about in terms of flow limitation or contrast hold up or what we call a vessel threatening dissection, those are the 2 reasons for them bailing out. So the point at which you then apply the drug is where you're happy that the job is done and you're simply just painting the walls and getting out, is the idea. Now, I made a faux pas here by treating with both drug-coated balloons at the same time and received a wrist slap fairly quickly because we should be doing this sequentially. So this is a 3.0 solution in the diagonal and a 3.5, so slightly oversized the distal vessel in the main vessel. But it should be really that you just inflate one in one vessel and then take the other into the other vessel. This is the final result. So we're making then that assessment. Are we happy? This concern historically about abrupt vessel closure is clearly my concern acutely with this patient. I'm going to take her off the table, and is there then a concern that she's going to come back? The IVUS, if anything, looks even more ugly. Again, I shouldn't have put the IVUS down, so I got another wrist slap because we shouldn't be passing any further devices. So we're learning, I'm learning, this is actually fairly early in our recruitment to this study. So acceptable result. The focus has all been on the LAD diagonal bifurcation, and as we commented, she had disease downstream, which was really what put you off the idea of a lemur graft to the LAD. So this issue around classification of dissection, I think, is a challenge. And interestingly, through the evolution of the study, there has been really a movement probably away from A, B, C, D, E, F, and kind of the agitation of does it look like a barber's pole or is it doing whatever? And it is now about non-flow limiting, flow limiting dissection. And so there is a fantastic evolution in terms of the understanding and our experience and confidence in terms of interpretation of this injury. Hey-ho. So she returns with a recurrence of chest pain. Many of my colleagues went, told you so, what were you playing at? This is ridiculous. So she comes through the rapid access chest pain clinic actually 8 months after the index event, having been describing some chest pain over the 3 to 4 months, but just kind of dealing with it. Her lipids have actually been well controlled. We'd undertaken a lipoprotein little a for what it's worth to actually show that she has relatively low risk in that sense. But look at that. Mm-hmm. I mean, that is pretty cool, isn't it? So I am happy. I mean, extraordinary, really. But sadly, it's the rest of her vessel. But conceptually then, we're in a different space. Antoinette talked about this idea that we don't leave anything behind. We have the opportunity to do more, to adapt our therapy without having lots of metal that might then complicate future revascs. Now, there could be an argument to say we should have treated this disease at the time, but for the simplicity of the trial and actually the simplicity of trying to maintain this procedure without the risk of bailout, I think we can justify just treating what was felt to be the culprit lesion. Just for interest, these are side by side. On the left, the original dissection at the index, and now this 9-month recovery, where we see really interesting healing of those dissections. So Carlo, that dissection that we were seeing was in that segment you were concerned about angiographically. And look now as we open up into the diagonal, just the most extraordinary healing. So, you know, this isn't a normal vessel by any extent, but it hasn't got in-stent restenosis. It just has the plaque that was always there, but a luminal gain, which is really quite tremendous. So this was actually undertaken by a colleague in terms of the subsequent treatment, and actually was then confident to proceed with further DCB treatment. So careful predilatation, interestingly, of both the mid-LAD and the small diagonal branch, with really lots of care and low pressure inflations, with really a very impressive POBA result. It is extraordinary as you do this and you move through using these sequential inflations and taking care in the preparation that you see how these vessels behave. Now you'll argue that actually there's distal disease, and I have to say if this were me doing the intervention now, I probably would commit to treating the downstream disease as well, but I think the argument here was just to not kind of outdo your luck. So we had preparation ultimately with a 3, and then a 3/20 solution was implanted with really a very good result, again in that more downstream segment. So I think it's an important case to share. It does demonstrate, you know, that complex bifurcation disease, where we could have had a whole afternoon talking about whether it's a DK crush or a DK culotte or a provisional strategy, and then thinking about the downstream problems with restenosis. We haven't had to do that. We have to acknowledge that dissection management is actually a challenge, and one that we have to learn and evolve, and hopefully with studies like SELUTION novo, we will gain tremendous experience that can be shared amongst the community. I think that the jury's still out as to where intracoronary imaging plays a role. It is essential where we're putting a stent, but it probably isn't so essential in the setting of DCB, but I think there's lots we could learn from it in this kind of evolution. And then the DEP approach, I think, does allow this stepwise sequential approach that where re-intervention is maybe something we shouldn't shy away from. But thanks for your attention.
Super, thanks very much. Great case. Anybody want to make some comments? Yes, please.
Thank you very much for your presentation. Just one question. I would have gone for physiological assessment more rather than imaging assessment, because as you said, if you use imaging, we reinforce the idea to prepare the lesion only on anatomical criteria. And maybe you can result in dissection that you don't want to leave, or you are not confident to leave. Also because we have to take into our mind that LID is the vessel in which a mismatch between the residual stenosis and functional assessment is most relevant compared to right and LCX. So in my mind, I think physiological assessment perform better compared to imaging in the setting of DCB application.
I mean, we love tools. We love adjuncts to kind of either make life more complicated or more simple. There's been data this week presented by Carlos Colle in terms of PPG, and with the burden of disease that she has, there's every chance we will have seen a diffuse pattern that would now teach us that probably stenting is the wrong thing. So I agree that the physiology would add some further information, but I think it might even persuade you more that a DEB strategy is preferred over extensive jacketing with metal.
May I do a counterpoint?
Yeah.
Mm-hmm.
So, actually, thank you for your arguments. I would argue that the imaging is actually more useful if we stick to two things, to proper sizing and to calcium evaluation, because that will give you a better preparation of lesion. And if you focus on the risk of occlusive dissection instead of on the data on the IVUS post-dilation, you will actually have used the data from the IVUS to really get a better preparation and higher lumen, and will not use the data to over-treat after. And then you can stick to the non-flow limiting linear dissection without contrast staining, and really don't use the IVUS to decide to implant a stent, but just to prepare the lesion. Because sometimes, and I think everyone has had this feeling, calcium is actually not very well evaluated by angiography. So you're thinking that you're dilating a soft plaque and you're dilating actually a really tight stenosis with calcium. And that's some information that only is derived by imaging. So I would do exactly what you did. So
Thank you.
I think.
Okay, super. Excellent comments. Thank you very much. So, Thomas, you'd like to go up and present a second case. The second case is slightly different in design and execution. Let's have a look.
Thank you, David. Very pleased to be here, and thanks for invitation. These are my disclosure slide. So my patient is 74-year-old male, had type 2 diabetes, hypertension, was ex-smoker with COPD, and very importantly, high bleeding risk because of mild anemia and anticoagulation. The patient was also frail and only moving mainly inside. He was admitted to hospital due to new onset of heart failure. Echo showed severe reduction in left ventricular function. We did, of course, catheterization in this patient. This is RCA, it's non-dominant, has moderate to severe stenosis in the mid part. And this is the left system. You can see that the LAD is calcified and there is stenosis right after the diagonal, which is also stenosed. And I think quite importantly, the quite huge septal branch originating just before the calcified eccentric proximal lesion. And also this disease extends to quite a long way in LAD.
Can I stop you there for a second?
Yeah.
For a show of hands. So just bear in mind the left side of the heart's not working, the right side of the heart's not working, and this is the coronary anatomy. Who fancies a go at this with angioplasty? Only Thomas, then.
Yeah.
It's quite a spunky case.
Yeah, well, I think the key points are here. The patient was truly inactive, frail, with COPD, low ejection fraction. Unfortunately, or fortunately, we don't have impella in our cath lab. Probably somebody would have put an impella in. These are the options. I think if you look at the revived study, you should maybe treat this patient only medically. Then there's, of course, as you mentioned, CABG. But we have options also for PCI. We have a primary DS approach, and because we are sitting in a DCB setting symposium, we have the DEB approach as well.
Yeah, anybody for CABG? I mean, when you say inactive and frail, that doesn't sound good. What sort of frailty due to anything in particular?
I think COPD.
Okay. So nobody for CABG. Medical therapy could be high on the list, possibly, you know, if you could get away with it. But let's say let's say he's come back and this is a second time. I mean, I think anybody want to make a comment? I mean, it's a bold strategy to consider drug-eluting balloon in this particular anatomy, but you have loads of experience.
But I mean, I guess you can consider it and you can try it, and if it doesn't work, that's why we have stents, right?
Absolutely.
So this is a high bleeding risk probably patient as well, elderly. I don't know what the other characteristics are, but it doesn't mean that you can't try, I guess.
Yeah.
No, absolutely right. I mean, you've got to do all the preparation anyway, so start.
Get away with it, great.
Yeah, Carlo, any thoughts about?
Just a comment. This patients will not be enrolled in the solution because the ejection fraction is below 30. So this is one of the exclusion criteria for the trial. But anyway, you can consider DB. And one major concern in my mind is to utilize hemodynamic support, because maybe in this the LAD is the major vessel in this patient, so the risk of hemodynamic compromise during the procedure due to the potentially need to rotablate or IVL, the risk of hemodynamic compromise is high.
Yeah, it's a good point, and I would like to also stress the bleeding risk here, and then also the very diffuse nature in LAD. If the patient was younger, less sick, I think we have to preserve the distal LAD for later limato LAD grafting. So it's important not to cage that part of the vessel. So we have options for also for calcium modification. Maybe we can discuss this part as well.
Well, yeah, I was going to say that, I mean, we had a comment earlier about the difficulty of angiography defining calcium. We quite clearly have severe high-grade tramline calcification, but then that makes the complexity of or the comorbidity for this patient even more of an issue. So it puts you off the idea of rotablation in the absence of potential protection, albeit no evidence for protection. We wouldn't have been able to recruit to SELUTION. We'd be recruiting to Devaka Pereira's CHIP BESIS 3 trial, where we'd have a 50-50 randomization to an impeller device. But that would probably push you towards doing something as minimally invasive. So IVL would be attractive in the absence of support as a first adjunct, thinking that it may require rotablation or some form of debulking if that failed, I think.
It's a great comment. Are you afraid that you cannot deliver IVL in that very proximal lesion? Of course, you can try, but you can, run into trouble as well. Okay, should I move forward?
Yes. Why don't you go forward? Show us what you did do.
So we have, I think, good experience at treating this kind of patients without hemodynamic support, and as Tom said, I think we don't have any clear evidence using that in elective patients in terms of randomized settings. So we decided after careful discussion with the patient to proceed with LAD PCI 7 French radial approach, and given the very tight proximal calcified lesion, we thought that IVL balloon very probably does not cross that lesion, and that's why we aim at doing rotablation and then using imaging guidance, and aim at either DCP-only approach or the hybrid approach. This is something you cannot decide beforehand. It's only after lesion preparation. So we selected the smallest burr. Of course, you can argue that there's a risk of entrapment, but we figure that there's a very high calcium burden, and the use of smallest burr will decrease the risk of slow flow in this vessel. So it went very well, and then we did OCD of this vessel. You can see that there's some space there in LAD, in the proximal lesion, to fit the catheter in, but there's a huge burden of calcium which is not affected at this point. So we thought that, of course, we could have selected IVL here, but in my experience, if you have that much calcium, it's very probable to have a significant recoil if you don't abolish the calcium with a larger burr. So we took 1.75 burr. We thought that stepping only one size up is not enough in this case because the lady is quite big in the proximal part. We used this burr only for the two most proximal stenosis. But as we were afraid, we had slow flow, but the patient tolerated this very well, and the blood pressure was so high or normal that we could even use nitroprusside in coronary. Obviously, we waited a bit for the next move, and then we dilated the LAD and diagonal LAD 3.0 cutting balloon with quite high pressure, and 2.5 NC balloon was used for diagonal branch and distal LAD at high pressure. Here you can see the predilatations. You can see that the balloon is quite nicely fully dilated. Here you cannot be sure. And then this is the smaller NC balloon. So here we have the predilation result after 2 runs of rotablation and then NC and cutting balloon. We have a little slow mebitum flow. This is obviously because of the microvascular dysfunction of the rotablation, and maybe you cannot here judge the flow, or you can judge the flow, but you cannot use flow as a judgment to use DCB or DS, I think, because it's not because of the ballooning itself. But there is recoil in the mid part of the vessel, and it's quite difficult because of the heavy calcium to see what is happening inside the vessel. So obviously,
So you're being quite harsh on yourself, because so far you've done an incredible job.
okay.
You know, and I mean, yes, there is some recoil there. Who's feeling like, you know, it's 3-0 up and it's half time and you're really winning and it's nearly time to put either your stents or your drug-coated balloons in? You want to do more work to it? If so, what? Any comments? I mean, I think it's looking so much better than when you started, and I'm thinking I'm tempted to look at some of those and think they're not more than 30%. You want to do some more, though.
Yeah.
I mean, hats off to you. You know.
Well, I think in this kind of long diffuse disease with calcium, I think intravascular imaging, either using IVUS or OCD, is compulsory, because it's very difficult to see the recoil. Of course, you can use different angles, but then there's calcium outside of the vessel, so I think we need imaging. And also to see if there are enough cracks in the calcium. We see cracks in the calcium, but if you look at the OCT run, we have, I think, significant recoil here in this part. Hopefully you can see the arrow, and here in the proximal stenosis. So I think we need more in this case. So we took shockwave catheter 3.0, and we used all the pulses here for the 2 proximal part, and now it's looking better. I didn't use OCT again because you have many runs already done in this patient. So, but angiographically, from 2 different angles, which is very important that you use 2 different angles, it looks fine. And you can appreciate the very poor movement of the anterior wall of this left ventricle. I think the flow is also improving a bit here. So at this point, we stop maybe and discuss what should we do at this point.
But this is a great case, and exactly as Antoinette said, all of this was required, whether you're going to do drug-coated balloon or stent. So it's having the drug-coated balloon in your mind, I think, makes everybody prepare things better than they did, because they think, oh, it's just okay, now I can just put a stent in and blow it up a bit harder. But actually this is concentrating our minds to do the job properly.
Yeah, absolutely. And if you put a stent before IVL in this case, I'm very sure that they would have been under expansion, and then you are truly in trouble, I think, yes. In this case.
So show of hands from the audience, if you had also Thomas's skills and had got to this point without killing the patient, who would feel confident that actually drug-coated balloon in this setting was perfectly reasonable? Yeah, so even though that the anatomy, if you like, at the outset looked pretty challenging, here we are 3/4 of the way through the case and thinking, actually, even in this case, we don't need to put a stent in. Any comments?
I think it's an incredible job, and very happy to raise my hand for
amazing job. Keep going.
Okay, so in our cath lab we always aim at DCB approach, and we are a little bit disappointed if we have to put a stent there. So I think this is ready for complete DCB or DEB approach. I tend to use the side branch first. If there's a little bit carina shift, it's in the benefit of the main branch. This is the first solution balloon for the diagonal, and then quite long solution balloons for the LAD. 60-second dilatations, and the patient tolerated very well. I think there is preconditioning because there was a very tight stenosis here. Sometimes we use a little bit ephedrine, for example, to sustain the blood pressure, but in this case it was not necessary. And this is the most proximal dilatation. So this is the initial final result. There's OCT catheter going on there. TIMI flow is okay. The patient was asymptomatic, and we planned to have 3 months clopidogrel on top of anticoagulation. And which is very important, the last figure should be taken without the wire. Of course, in this case, because the vessel was so calcified, there are hardly no dissections in this vessel. We did this OCT, and you can appreciate quite nice cracks in the calcium, and in the longitudinal view, there's no significant recoil, I think, anymore. We were very happy to have control angio on these patients 2 months after SELUTION DCB treatment, and the flow is normal, and I think you can see some positive remodeling in this case. We know that we see it very often after paclitaxel-coated balloons, but it's less pronounced in the limus balloons. But in this case, we were very satisfied with the result. So I would like to conclude that DCB is a good option for diffuse disease, especially in the LAD. We do not cage the vessel for later cappage, for example. Bifurcation PCI is very simple. It's a good option for HBR patients. Adequate lesion preparation is needed both for DCB and stenting. We need imaging in this kind of complex PCI. And interestingly, in the first SELUTION paper, this observational paper, there was 2/3 of the patients, they had moderate to severe calcification. Not that much treated with rotablation, but almost half of the lesions were treated with a cutting balloon before DCB. So thank you for your attention.
That's a fantastic case. I mean, I think what Thomas has shown there is that, in a sense, there are no limits. You know, you prepare until you get to the point where you would either use drug-coated balloons or put in a stent. But I think the more we think about using drug-coated balloons, the more we do better and better preparation and take our time making sure we've really prepared the vessel properly. And that's going to be greatly to the patient's advantages in the long term. So I commend you for doing such a tough case like that. It's a fantastic result, but I think it's really educational for us to see the results that you were able to get. Plus the follow-up. So I hope that's enthused everyone in the audience to think, okay, I could go home and I can do something similar. So our time is up, but thank you ever so much for coming for this session.